My name is Yusuf Yazici, and I'm a rheumatologist at the NYU Hospital for Joint Diseases in New York. I divide my time between seeing patients and also running the clinical trials related to rheumatoid arthritis and vasculitis, especially Behcets Syndrome at New York University. And we've been involved with all levels of and kinds of different clinical trials, patient-reported outcomes related, registry-related, industry-sponsored, and investigator-initiated clinical trials looking at both treatment, long-term outcome, and patient outcomes. One of the main reasons probably why I got involved in rheumatology and also Behcets is my father is also a rheumatologist in Turkey and has done a lot of work with Behcets. And we've been working with him over the years in both when I was training, I trained where he was, and then also continued our relationship through clinical trials and other investigations that we did, not just in Behcets, but also other areas in rheumatology. Behcets syndrome is a systemic vasculitis. It's grouped under the vasculitic conditions that presents with most commonly oral ulcers, genital ulcers, various skin lesions, inflammation in the eye, and also at least some of the patients with inflammation in the gastrointestinal system. Most patients also have non-deforming arthritis, so that's why one of the reasons why rheumatologists see these patients. It has a unique geographic distribution in that it's more commonly seen in patients from the Mediterranean area, especially Greece, Turkey, Israel, Middle East, North Africa, Far East, Korea, Japan, and China. It also happens that these areas were along the path called the Silk Route, and it's sometimes referred to as the Silk Route disease because these populations over the centuries maybe possibly spread out the disease over the same geography. It's also different than some of the other rheumatologic and vasculitic conditions in that males are more commonly and more severely affected than females. And they tend to get their disease in the third and the fourth decade in life. So the most severe patient usually is a young male patient. And however, in our experience in the US, we tend to see more female patients, but in centers around the Mediterranean, males seem to be a little more common, definitely more severe. The treatment of Behcets syndrome it really depends on what symptoms the patients are presenting with. An interesting aspect of the disease is that the natural course of the disease is one of waxing and waning, and in about 2/3 of the patients getting better over time with treatment and time. So keeping that in mind, we're usually very aggressive with treatment early on, knowing that we have an opportunity to turn off the inflammation and basically get rid of the disease in many patients. That doesn't happen in everybody, of course, but we have to give each patient that opportunity to hopefully respond to treatment. And the main cutoff when we're using different medications and making treatment decisions is that if the patients have eye disease or not, or if they have any systemic involvement or not. The patient, the most common patient that only has mucocutaneous involvement, so oral ulcers, genital ulcers, various skin lesions, can be treated with mild medications like colchicine, hydroxychloroquine, low-dose prednisone, or even topical treatments. And with managing those symptoms, they tend to get better over time, and they use less and less medication. However, if the patient has eye disease or other systemic organ involvement, then we have to start with the immunosuppressive drugs, either alone or in combination with steroids, and sometimes even combining 2 or more immunosuppressive drugs. Those patients also tend to control their disease and get off the medications, but it usually takes longer, up to 5 years and more, until we can get the disease really under control and feel confident enough to take off the medications. If you look at the frequency of various manifestations of the disease, over 90% get oral ulcers, over 80% of patients get genital ulcers and skin lesions, about half the patients get eye disease. But if you look at only the males, that number goes up to about 70% of young male patients especially, who get inflammatory eye disease. The good thing with eye disease is that it is usually present at the beginning of the disease. It will be rare to get new eye disease after 5 years, so we can gauge how severe the disease is going to be within the first years of manifestation starting. Vascular involvement, inflammation of the blood vessels leading to either aneurysms or blood clots, can also be seen, along with central nervous system involvement, which are the most serious and hard to treat, but they're usually seen less than 10 to 15% of patients. One of the reasons we prefer calling the disease Behcets syndrome rather than Behcets disease is that there seems to be different pathways and pathogenetic mechanisms for different manifestations of the disease. There have been analyses done which are called cluster analysis, looking at different symptoms of the disease and to see if certain symptoms go with others. It's been shown that skin involvement and arthritis tends to go together, oral and genital ulcers go together, and blood clots and other pulmonary vasculature problems, aneurysms and things like that also tend to go together. So if we see one, then we usually look for the other, especially in the case of a patient that has a blood clot in their legs, and then they would tend to have more pulmonary aneurysm, which is the most common reason for mortality in Behcets. So we would do a CT scan or other examinations to make sure that they don't have one that's slowly evolving. As I mentioned, most patients with time and treatment tend to do well with Behcets. So it's very different than other, not just vasculitic conditions, but other rheumatologic conditions, that it's not really a fatal disease. It responds well to treatment, not in everybody, but 2/3 of patients have a very good chance of leading normal lives without medications after enough time on treatment. Mortality, when seen, is mostly reserved for young male patients who present with eye disease and other systemic inflammatory conditions. One of the challenges that the patients have with Behcets, given that they get skin manifestations like acne, oral ulcerations, genital ulcerations, is the worry that this might be contagious. However, Behcets is not a contagious or an infectious disease. You didn't really get it from anybody and you can't give it to anybody. It's an inflammatory condition, body's own cells turning on certain tissues in the body. And that's why we usually use immunosuppressive medications to kind of calm down those cells until the overactivity is done. But it's not a contagious disease and patients should not worry about that. For a newly diagnosed patient, the most important thing to remember is that most patients with treatment and time will do well. So knowing that, I think, is a big advantage, that you have a clear goal and a time frame where your doctor can review the medications they're going to use, what the expected outcomes are at 1 year, 2 years, and 5 years. And if you're not meeting those outcomes, then treatment can be modified. It's important to make sure that there is no, even if the patient doesn't have any symptoms, there is a full eye exam that's done to make sure there is no mild inflammation in the eye, because if there is eye inflammation, the treatment changes for those patients who don't have eye inflammation. They can both be treated, both types of Behcets can be treated, but it's just different medications, so we need to establish that. As we're giving immunosuppressive drugs, it's important to follow up with the doctor, follow up with the required blood tests and other testing that might be needed throughout the course of the disease.